great to be here at my sister organization. So what we're going to do is, as Galen introduced, it's going to be kind of a bench to bedside, because this really is an incredibly remarkable story in the last few years where we've revolutionized the care we can give some of our more severe asthmatic patients. And it's a story that's been going on for about 20 years with lots of failure that we'll talk about, but ultimately leading to a time when, for a lot of people, these new drugs are game changers. So this is probably an important slide. I get a number of University of Virginia grants, not only from the NIH, but from several of the companies that I'm talking here. I'm going to talk about drugs from GSK and Regeneron. All of that money goes to the University of Virginia. I don't see anything from that. I'm on one advisory board, and I'm not talking about any of their products, but I will be talking about Regeneron and GSK products. So the current situation in asthma medicine, actually the joke I always give is, in America in 2020, if the batteries on your remote control die, and you actually have to get off the sofa to change the channel, and you get short of breath doing that, somebody is going to diagnose you with asthma and give you an Advair prescription. The current situation is patient has lung symptoms, intermittent shortness of breath. It seems maybe consistent with asthma. If this is happening more than once a week, we go to the NAEPP guidelines and say, let's use an inhaled steroid. All that is based on the assumption that it is asthma, first of all, and this is a steroid responsive type 2 meaning eosinophilic, IgE, the appropriate interleukin diseases. And if after you've added one inhaled steroid, a second long-term controller, a third long-term controller, patient's still not getting better, add a biologic. So this leads to the question of the challenge of the very poorly controlled asthmatic. Now, Don's going to go into the numbers in more detail. This is 5% of Americans have asthma. We're talking the tip of the iceberg. It's 10% of the asthmatics who are these severe patients, but it's a huge percentage of healthcare costs and loss of quality of life. The most important question, and I'm not going to talk about this all, it's a whole other lecture, is the disease actually asthma? Vast differential diagnosis. Another 1-hour talk that I won't get into. Is the patient actually following any of your recommendations? The whole compliance problem. What I will talk about is the fact that asthma is a wastebasket term. It's intermittent shortness of breath caused by inflammation in the airway, but that inflammation can be caused by numerous molecular processes, and we have to know what they are because we need to be doing individualized disease-specific therapies. I'm going to go through a couple of these, and the key ones are that we have this non-eosinophilic disease, and I'm going to go through a couple of the eosinophilic disease. Now, this is our University of Virginia study. 189 consecutive children get referred to our group with severe, uncontrolled, what's called problematic wheezing, and the decision is made that they need a clinically indicated bronchoscopy. Part of the research protocol is if you're having a clinically indicated bronchoscopy, you can consent for additional materials to be sent to my laboratory where we can look at the bowel fluid tissue, do cytokine analyses, and so forth. 189 children with severe treatment-resistant asthma. What percent have eosinophilic diseases? You see the percentages here, and these are validated numbers from the NIH Severe Asthma Research Program. Pure eosinophilia, only 8.5%. Now there's another group of mixed granulocytic, that's 22.2%, that's eosinophil neutrophils. Only 30% have evidence of a type 2 disease. Isolated neutrophilia is 24%. The largest group actually doesn't even have granulocytic disease in their airway. Now they are all on high-dose steroids, most of them are on prednisone, so that's influencing the story. But if your goal is to eliminate the eosinophils and there already aren't any, adding more steroids or an eosinophil targeted biologic isn't going to help that person. So that's the University of Virginia. This is the University of California, San Francisco. They did bronchial biopsy from a bunch of volunteers. They're defining type 2 disease by the classic type 2 cytokines, IL-4, 5, and 13. And if you just look at the red and the blue, those are the asthmatics. Total of 50 patients, 28, 50% have type 2 disease, high IL-5, IL-13. Fully 44%, their cytokine levels are no different than what you see in the control subjects. So again, huge percentage of what we're calling asthmatics don't have this eosinophilic type 2 disease. And in that UCSF study, just look at the bottom part of the table. If you look at the eosinophils in the airway, no big surprise. If it's the Th2 low signature, their eosinophil numbers are no different than the controls. The Th2 high signature on the far right and the bottom, that's where the eosinophilic disease is. One last study along these lines, this is from New Zealand. This is neat because they wanted to get rid of the variable being directed by the fact that, heck, these patients are all on inhaled steroids or prednisone. So stop all the steroids, go 28 days, let the steroids wear off, or wait till the patients start to get symptoms, but not too many symptoms, because then they're going to do this bronchoscopy. And they look to see who's got the eosinophils. 60 eosinophilic, 28 don't have an eosinophil disease, about 2/3 there. Even in the amplisteroids, the implication is for this study is that probably about 1/3 of our asthmatic patients don't have a type 2 disease. So what is this non-eosinophilic disease? Pathologically, it can be neutrophil predominant, and the immunology is it's not Th2, it's the other T effector patterns. Type 1, lots of interferon gamma. Type 3, which is Th17, and I'll talk a little bit about it. But the key is these are cytokines that drive T-cell mediated neutrophil recruitment and activation. So this goes back to our study that I showed you a little while ago, where we're getting the bowel fluid from all these severe asthmatics. And in this study, you can look at a nice correlation between how much IL-17 you have and how many neutrophils. The closed and open circles aren't important. That's whether or not they're on steroids. This is our data now looking at interferon gamma. And for human research, on R squared is actually 0.52. The more neutrophils you have, the more IL-17, the more IL-1. It's not a type 2 disease. So 1/3 of asthmatics don't have a type 2 disease. Why is that interesting to you all who see these patients? Steroids don't work if you don't have an eosinophilic disease. Steroids, my joke is an eosinophil cannot survive in the same hemisphere where there's a molecule of cortisone. Cortisone is incredibly effective at killing an eosinophil. And it also blocks the production of IL-5, which eosinophils need to differentiate and survive. They have the opposite effect on neutrophils. Steroids inhibit neutrophil apoptosis. When you take somebody with a neutrophilic disease and give them steroids, what you get is more neutrophils. So arguably, they exacerbate neutrophil-mediated inflammation. Now, this is the UCSF study, and the red, remember, were the type 2 high patients, the blue were the type 2 low patients. After they determined who was who, they put the patients back on their inhaled steroid, and what you see in the red group, remarkable improvements in FEV1, 400 milliliter improvement in lung function. What happens in the blue group, the Th2 disease? If anything, that's the statistically significant worsening in lung function. So first-line treatment for asthma, inhaled steroids. P-values look great because if we take 100 people, 60 to 70 of them do really, really well. But we're using a drug that won't work in fully 1/3 of our asthmatic patients. This is the New Zealand study, where again, they put the patients back on the inhaled steroids, and I'll just highlight the FEV1 data, which you see here. If you had eosinophilic disease, 80% of them got better, no big surprise. If you didn't have eosinophil in your airway, only 14% got better. And there's nothing new under the sun. 1958, steroids had been around and available for just a few years. This study comes out in Lancet. And this is the title of the study, Treatment of Chronic Asthma with Prednisolone, Significance of Eosinophils in the Sputum. In 1958, they knew if you don't have eosinophils, your asthma is not going to get better with steroids. Yet there's our guideline saying first line for everyone. We're going to talk about the type 2 biologics, but again, what we have now are biologics that target type 2 disease. And if you don't have type 2 disease, the biologics won't work. So amongst the eosinophilic disease, there's a number of phenotypes. I'm just going to talk a little bit about allergen exacerbated and pure eosinophilic disease. The immunology of the allergen-exacerbated disease is type 2 high, and I'll say this briefly later, it's IL-4 that is driving IgE production. You can diagnose the allergy component with skin testing if available. Immunoassays are very good, but the key is 60% of the 60% of the audience here has IgE to something, and half of you don't have an allergic disease. Just having IgE is not the definition of allergic asthma. It drives me crazy. The joke I will give the medical students is, what percentage of non-allergic asthmatics have positive skin tests? The joke begins with, what is allergic appendicitis? And the way the joke goes is, if somebody comes into the UVA emergency room with right lower quadrant pain, rebound, high white count, they call me so I can do skin testing. And if the skin tests are positive, then I've diagnosed allergic appendicitis. 60% of UVA patients have allergic appendicitis. 60% of Americans have positive skin tests, is the point. 60% of patients with non-allergic asthma have positive skin tests. You can't diagnose an allergic disease by a skin test. You diagnose it by taking a history that the person has allergens that actually worsen their upper and lower airway symptoms, not just a positive blood test. The implication is, if you really do have an allergen-exacerbated disease, avoid the allergen if you can. My joke is patients will get rid of their doctor. They will never get rid of their cat. Allergy shots may work, omalizumab, and the drugs that we're going to mostly talk about this morning. So this is the study. I would have sold my eye teeth to get involved in a few years ago when it was done. Pause. You can't be an allergist, asthma specialist. One of the absolute requirements is that you are required to have worse asthma than any of your patients. So I get to be in all these studies. And this was the best study ever because they took a bunch of asthmatics and brought them to Davos, and then you got to spend 4 months in the Swiss Alps seeing what happened to your asthma. Now, who wouldn't sign up for that study to be paid to be in Davos? And the end of those 3 or 4 months, these were the data, which shows, going from left to right, the lung function did get a lot better. It went from 77 to 122%. But when you actually looked at markers of inflammation, the eosinophils in the sputum, PC20, that's a measure of airway inflammation, didn't really change a whole lot. Removal from the environment improves, it doesn't eliminate the asthma. And there was some improvement in lung function, quality of life, rescue drug use, but asthma doesn't go away. And my takeaway point is I hate the term allergic asthma because there is no such thing as allergic asthma. There is a disease of allergen-exacerbated asthma, but asthma is a lifelong transformation of the airways. It persists independent of allergen exposure. It does not go away. It's like Crohn's disease, multiple sclerosis, all these other diseases. Once you have it, that's permanent. Allergens can make it worse, and we can target that. So I'll just jump to one of the biologics, which is omalizumab. And omalizumab is an anti-Ig antibody. It captures IgE in the bloodstream. That's just been produced by the B cell. And by capturing the bloodstream, it can't bind to mast cells or basophils and is no longer available to cause mast cell or basophil activation. The FDA approved this drug 20 plus years ago, and it was based on these data: prevention of exacerbations, about a 50 to 60% reduction of pediatric or adult exacerbation rates, which is pretty remarkable. Last phenotype I'll talk about is the eosinophilic disease. The immunology here is these patients may or may not have an allergic component. Actually, the worst asthmatics I see are these adult onset asthmatics with high eosinol numbers, and they're not allergic at all. So, what is the immunology? Lots of IL-5, that's the eosinophil poietin, not so much IL-4, which is what you need for IgE. There's a lot of immune cells besides T cells. These innate lymphoid cells that produce IL-5 and 13 but not 4 are getting a lot of press in our literature. But the bottom line is they have eosinophilic disease of the airway. Therapeutic indication, these are the people, these are our patients where steroids are actually working because eosinophils, as I said, will be killed by corticosteroids. And we have the biologics. Anti-IL-5, and John will talk about it, it almost died because when these drugs came out, they gave it to all asthmatics, And when you study all asthmatics, it turned out you couldn't find a signal of benefit. These drugs were rescued because they needed to identify patients who were on high-dose inhaled steroids, or oral steroids, still had an eosinophil signature. And those are the patients where you've shown that the steroids have done what they can, they're not doing their job, it's a type 2 disease, and now, just as with omalizumab, you get these kinds of studies that came out in the same issue of the New England Journal, showing remarkable improvement in exacerbation rates, especially 50% or more reduction in exacerbation rate. But you had to have severe asthma, and for these studies, you had to have eosinophils in your sputum in order to get into the study. The improvements in lung function were there, not quite as strong. So let me turn to what's really going to be the focus of our presentation, which is this novel therapy and a real neat bench to bedside story. I'm going to talk a little bit about the unique activities of IL-4 and IL-13. Don't get lost in the detail. All I really want to point out is there's a real advantage to being able to block both IL-4 and IL-13 because they don't do the same thing. They do a lot of similar things because they share one component of the receptor. So there's two types of receptors. On your left, you'll see the type 1 receptor. That's the IL-4 receptor chain with what's called the common gamma chain. Only IL-4 can bind that. There's an type 2 receptor, which is that same IL-4 receptor alpha chain, but a unique IL-13 receptor alpha chain that both receptors use. So what's neat, jumping ahead, is that if you make an anti-IL-4 receptor antibody, you block both receptors. You block the biological activities of IL-4 and IL-13. And these receptors have different patterns of expression. So the type 1 receptor, the one with the gamma chain, tends to be restricted to hematopoietic cells. It's what's on T cells, it's what's on mast cells. Basically, only IL-4 will activate those two cell types. IL-13, the type 2 receptors, far more widely expressed. And that's going to influence what these things do. So the receptors are in different cells, they have different targets. So IL-4, one of the other unique features of IL-4 is that it's paracrine. The cell that's making it squirts it onto the cell next to it. IL-13 is a hormone. So even though IL-4 in theory could act, and I'm going to show you these data, act on epithelial cells to cause mucus production, it doesn't because it's not there. You can't measure IL-4 in bowel fluid, in the blood, or anywhere. It cozies up next to its target cell and spits the IL-4 on that target cell. The B cell to make IgE, the mast cell to do all sorts of harm. It's IL-13 that is messing up the airway in ways that I'll show you in a moment. So this is the classic study that I was a fellow at the time, and I don't know what I was studying, but when Bill Paul published this, we all became IL-4 biologists. And this is the study that shows that when you take a B cell and you incubate it with IL-4 and across the x-axis is a dose response, that B cell devotes itself fully to making IgE. And that's an activity of IL-4. IL-13 will do that in the test tube. It absolutely doesn't do that in life because the cell that's in the germinal center making this happen is a follicular T cell that only makes IL-4. Don't get bogged down in the details. The key takeaway message is you have to block IL-4 and IL-13. I mentioned the type 1 receptors, what's on the mast cells. IL-4 acts on the mast cell to greatly upregulate IgE receptors, and the term I like to use is it makes leaky, angry mast cells. When IL-4 is around those mast cells, if you look at them cross-eyed, they degranulate and produce a hive or an asthma attack or whatever. The most interesting thing about IL-4 is its role in Th2, in actually driving the Th2 disease. So you have this allergen being taken up by a dendritic cell, it gets presented to a naive T cell. That naive T cell produces a little bit of IL-4, which acts in an autocrine fashion to drive the terminal differentiation in that cell. And that newly differentiated Th2 cell now is long-lived and permanently differentiated to make not only IL-4, but IL-5 and IL-13. You block IL-4 with an anti-IL-4 receptor antibody, you really block the ability to make a Th2 cell, and then all of those Th2 cytokines disappear. So this is a neat little study in vitro, which really points to that, which is where you take naive T cells, incubate them with an antigen. It happened to have been ovalbumin peptide, and you see how much interferon gamma in the second line down and how much IL-4. If you throw IL-4 in the mix, the more IL-4 you have, the more IL-4 that T cell starts to make. The rich get richer, the allergic get more allergic. But if you give that anti-IL-4 antibody, you completely abrogate the ability of those cells to become Th2. So a real neat reason for targeting IL-4 receptors, yet stop making Th2 cells. So I'm not going to steal John's thunder. He's going to talk really about the clinical benefits of this drug, but this is the stuff that I always joke about, the long winter nights in Charlottesville, where I think about all of these important immunology problems, which in New Orleans I can get away with, but I once complained about the long winter nights in Charlottesville when I was at the Mayo Clinic and got no sympathy whatsoever. But this is IgE concentrations, and it really points to the fact that if you give somebody an anti-IL-4 receptor, over time the IgE disappears. You're blocking that B cell isotype switch. And we've only had these drugs for a few years, and I'm just fascinated by what's going to happen. This is 1 year. What's going to be like 2, 3, 4 years? I mean, there's real potential for disease modification. Now, when you put people on an anti-IL-4 receptor, for reasons I'll get to in a second, the eosinophils initially shoot up, but then inexorably the eosinophils start to disappear, which points out that we're doing in vivo what I showed you in the in vitro experiment a moment ago. We're blocking Th2 differentiation. This is the disappearance of IL-5, and again, that's a 52-week study. If we give people these drugs for 2, 3, 4, 5 years, can we permanently, if you will, reboot, reprogram the immune system? So that's IL-4. IL-13, that's the hormone. It's acting at a distance. It acts on endothelial cells. I'll show you why that's important in a moment. Smooth muscle hyperplasia, the thickened bronchospastic airway that causes the wheezing, bronchial hyperactivity. So start with the endothelial cells. It is IL-13 that causes the upregulating of VCAM. That is the receptor on the endothelial cells that eosinophils need to get out. And the other thing it's doing on those cells is it's driving the production of chemokines, the eotaxins. So if you block IL-13, I showed you the eosinophils shooting up a moment ago when you start anti-IL-13 receptor. And the reason for that is they're trapped in the circulation. Because when you give people IL-13, anti-IL-4 receptor, there's no mechanism of eosinophils to get out of the circulation and into the tissue. And then we have this whole process of goblet cell metaplasia. In the presence of IL-13, a healthy epithelial cell with cilia on the surface that'll push everything out and be wonderful turns into a mucus-producing goblet cell. And that's obviously a problem. And between the smooth muscle hyperplasia, mucus production, epithelial denudation, that's what's driving the bronchial obstruction and hyperreactivity. So you dump IL-13, this is a mouse study, it's the only mouse study I'm going to show. You basically turn all those healthy epithelial cells into mucus-producing cells, exactly what we see in the airway of our asthmatic subjects. So, summary statement, IL-4, stable Th2 differentiation, Ig switch, mast cell activation, IL-13, eosinophil egress out of the circulation into the airway, mucus production, goblet cell hyperplasia, twitchy airways, fibrosis. So these are the reasons why the targeting of the IL-4 receptor is so inviting. So last slide, summary. Asthma is a wastebasket term comprising numerous distinct diseases. Each disease has its own unique pathogenic mechanism and deserves its unique therapy. And asthma treatment needs to be individualized. For refractory, steroid non-responsive type 2 high disease, blocking the IL-4 receptor is an inviting target. So that's where we were about 5 years ago in our science, and now we can go from the bench to the bedside, and I'll turn the second half of this symposium over to my friend John Oppenheimer. Thank you.